Hello, this is Dr. Lloyd again for Chapter 26, Fluid, Electrolyte, and Acid-Base Balance. Okay, so let's look at the major fluid compartments of the body. We have about 40 liters for the entire person, and about 40% of that is going to be intracellular fluid, about 20% extracellular fluid, and then about 20% is going to be plasma. Okay, so let's look at the ions responsible for the different compartments. So firstly, notice that sodium is high in the plasma and the interstitial fluid, but is low in the intracellular fluid. So sodium is low in cells, but is high outside of cells. Now potassium is different. Potassium is really the opposite, so it's going to be high inside cells intracellularly. And potassium concentration is low on the outside. Now the high sodium on the outside, the high potassium on the inside, this is what allows membrane potential to be established and a lot of work to be done. Okay, calcium is pretty much low across the board. It's sequestered because it's a highly potent ion. Magnesium is a little bit high in cells. We've got bicarbonate, which is going to be our buffer outside of cells. Chloride is an interesting one. It's high both on the inside and the outside, and chloride just kind of moves the way that it wants to move, depending on the conditions. It can go out of the cell or it can go into the cell. Then we've got some anions here, some phosphate and sulfates, and then there are protein anions, which are mostly DNA, that will give the cell a net negative charge. Okay, so the different systems, the lungs, the GI, and the kidneys, maintain interstitial fluids and blood plasmas. So what the lungs do is they take in oxygen, get rid of carbon dioxide. The GI tract absorbs nutrients, waters, and ions. And then the kidneys filter the blood of nitrogenous waste, like urea. Okay, so what about water intake? So most of the water that we take in is through beverages. Um, that's about 60%, and 30% are taken into the foods, and then about 10% through metabolism. And then we lose water mostly through urine, about 60%. And the next category is the insensible loss via the skin and the lungs. When you are humidifying your airways, you lose water. So urine is the major source of water output, but also insensible loss via the skin and the lungs. And then we've got a little bit of sweat and feces. Okay, let's look at thirst. So sodium in the extracellular compartment is very important. That's going to establish our osmolality. And there are receptors that will sense this salt concentration. Also, decreased saliva is a key off, but this is both of these high sodium and dry mouth will activate the hypothalamus, which is the location of our thirst center. So then we drink fluid, and the osmolality decreases, but the plasma volume increases. Now, when there is increased salt in the extracellular fluid, um, one of the mechanisms is to release angiotensin 2, which is a vasoconstrictor, which is then going to conserve volume, and it's going to increase plasma volume and decrease the osmolality. So angiotensin 2 is our vasoconstrictor, which is going to try to get the blood pressure back up here through thirst. Okay, antidiuretic hormone released through the posterior pituitary, very important hormone for maintaining water balance. And so let's say there's increased extracellular osmolality, which would be like increased sodium. Um, Sodium is the best indicator of hydration in the body. So high levels of sodium will correspond to high levels of water. So, but the high sodium stimulates osmoreceptors, which are then going to release antidiuretic hormone. So, um, just imagine that the salt concentration is high. What do you want to do? You want to conserve water to decrease that osmolality back to homeostatic levels. And you're going to do that through decreasing urine volume and the release of antidiuretic hormone to the posterior pituitary. Then there are also baroreceptors in the atria, and these respond to blood volume. And so decreased blood volume is going to decrease the output of these baroreceptors, but they're then going to stimulate antidiuretic hormone released from the posterior pituitary to try to get that volume back up. So there are disturbances in water balance, like dehydration, so excessive water loss from the extracellular compartment. The end result is the cells will lose their water and they will shrink, and this all occurs via osmosis. So let's look at some ions. Sodium is also referred to as natremia or natria. So hypernatremia is increased plasma sodium levels. And sometimes this is caused by dehydration. You don't have a lot of water, your sodium levels are high, and the consequences are increased thirst. Hyponatremia, where you have decreased sodium, this is when you have solute loss or water retention. It could be excessive vomiting, where you're losing the water. It could be diarrhea, burns. And hyponatremia is associated with neurological conditions, brain swelling, interestingly. Then we've got kalemia, which is potassium. So hyperkalemia, high potassium. This is a result of nausea and vomiting and diarrhea. There's also hypokalemia. Now, this is actually a very dangerous condition because the potassium is so important with the heart contractions. And so the consequence of hypokalemia or decreased potassium is cardiac arrhythmias, muscle weakness, mental confusion. Okay, chloride is interesting in that chloride just kind of goes the way that it wants to. So you have increased chloride with really no direct clinical symptoms. Decreased chloride, because chloride will move the way that it wants to at a given time. So calcium, hypercalcemia, this could be due to thyroid problems or excessive vitamin D. Hypocalcemia leads to tingling fingers, tremors, skeletal muscle cramps. And then magnesium is very important for the central nervous system. High magnesium is associated with lethargy and impaired CNS function, coma, depression, cardiac arrest. And hypomagnesemia results in tremors and tetany or contraction of the skeletal muscle without relaxation and convulsions. So sodium concentration is very important in the plasma compartment to maintain blood volume and blood pressure. There are osmoreceptors and there are baroreceptors. Osmoreceptors will detect the osmolality or the salt concentration, and the baroreceptors will detect the pressure. And the primary regulators of sodium is ADH from the posterior pituitary, as well as the renin-angiotensin-aldosterone A&P system. So that's RAS and A&P together. Those are the primary regulators of sodium content. So let's look at that a little bit. The mechanisms of aldosterone release. Now, aldosterone release is from the adrenal cortex. A couple different things can stimulate aldosterone release. If you remember that aldosterone leads to capture of sodium in the kidneys or reabsorption, then you can remember that decreased sodium content will activate aldosterone to reabsorb that sodium back to homeostatic levels. Also, increased potassium or hyperkalemia can also lead to aldosterone levels, because aldosterone levels, in addition to sodium reabsorption, will lead to potassium secretion. Atrial natriuretic peptide or atrial natriuretic factor is a very important hormone released from the atria upon stretch. So that's increased blood pressure that the atria detects. A&P is released. It then acts on one of three places. The first would be the kidney granular cells. These cells release renin. Renin activates this potent vasoconstrictor, angiotensin II. And so what you're going to do is A&P is actually going to shut off the renin system. It's going to shut off angiotensin II, leading to vasodilation, and that's going to decrease the blood pressure back to homeostatic levels. Now, A&P also operates at the hypothalamus and posterior pituitary to affect antidiuretic hormone release. So when you've got a lot of blood volume, you're stretching your atria, you're releasing A&P, you'd want to decrease your antidiuretic hormone so that you lose more volume via urine or glomerular filtration. That's going to bring down blood pressure. And then A&P also activates, will inhibit the aldosterone system. So the aldosterone is going to, if you inhibit it, is going to decrease sodium reabsorption and therefore decrease blood volume. Now remember that sodium concentration in the extracellular compartment is the greatest determinant of blood volume. Okay, mechanisms regulating sodium and water balance to maintain homeostatic levels of mean arterial pressure. So when there's a decrease in mean arterial pressure, we have decreased stretch, decreased A&P released, the renin, angiotensin, aldosterone system is shut down. You also have your baroreceptors with decreased blood pressure. They're going to stop firing, and the result is going to be increased peripheral resistance We have action on the posterior pituitary with antidiuretic hormone to reabsorb water. So let's summarize what happens with decreased blood pressure. There's decreased stretch. A&P is not released, and that's going to shut down the renin, angiotensin, aldosterone system. The decreased blood pressure is going to decrease firing of baroreceptors. That's going to lead to vasoconstriction and increased peripheral resistance. And then the posterior pituitary releases antidiuretic hormone, which is going to increase water reabsorption. So these 4 different mechanisms will increase blood pressure to homeostatic levels. Okay, let's talk about calcium. Now, calcium comes into the body through either the bones. You can have increased osteoclast activity, so you actually break down your bone and release your calcium and phosphate. Parathyroid hormone also increases calcium reabsorption in the kidneys. And then also activates vitamin D, which will increase calcium absorption from the intestines. So without vitamin D, calcium floodgates just do not open, and you will have a calcium deficiency. Okay, just really quickly, acids, strong acids will dissociate 100% into their components, whereas weak acids don't dissociate 100%. They stay in a couple different forms. And so we've got hydrochloric acid completely dissociating, and looks like we've got bicarbonate that is partially dissociating. So the bicarbonate buffer system is very important. It's a weak base and operates mainly in the extracellular fluid, but also in the intracellular fluid. There's then phosphate buffer system, which is a weak base, but phosphate buffer systems are important in urine and intracellular fluid. And then there's a protein buffer system with amino acids and side chains and different proton donators and acceptors. All right, so let's talk about acid-base balance. The respiratory system and the metabolic system are linked so that acid-base imbalances can be controlled more readily. So let's say we've got respiratory acidosis. This can be an indication of hypoventilation or impaired lung function, maybe chronic bronchitis, emphysema. So respiratory acidosis is when the respiratory system becomes acidotic because of decreased ventilation, and you've got some lactic acid buildup and decreased pH. Then you've got respiratory alkalosis, which could be a result of hyperventilation, strong pain, anxiety, fear, panic. Then on the metabolic side, metabolic acidosis, this can be caused by severe diarrhea, renal disease, untreated diabetes. There's metabolic alkalosis, maybe vomiting when you vomit off all of your gastric acid. So vomiting can lead to metabolic alkalosis. Okay, that is the chapter. I'll see you in the next one.